All right. So, hi, everyone. Good evening and welcome. We're so glad to have you here for tonight's webinar on unexplained infertility with Dr. Hannam as part of our Fertility Guide webinar series. Hi, everyone. My name is Mimi. I am the Fertility Friends Foundation coordinator. And just in case you're not familiar with us, we're a Canadian charity that provides grants to cover the costs of fertility treatments, including IVF, egg or sperm donation, and surrogacy. We're also very passionate about providing education and support to individuals and families that are navigating their fertility journey. Just a quick note, our current grant application cycle is opened until April 30th, so the end of this month. So if you or someone that you know could benefit, please feel free to apply for the grant. It's on our website, fertilityfriendsfoundation.com. We're also currently running our Green Ribbon campaign to help bring awareness to fertility challenges and show support for those that are currently undergoing this journey. And wearing a green ribbon can be a really simple but meaningful way to start conversations and build community, and that's also available on our website. So, tonight we're talking about unexplained infertility, a topic that affects many individuals and often comes with a lot of uncertainty. So, we hope this session can give a little bit of clarity and provide some practical takeaways. And with that, it is my pleasure to introduce our speaker tonight, Dr. Tom Hannam. Dr. Hannam is a leading reproductive endocrinology and infertility specialist and the founder of Hannam Fertility in Toronto. And he's well known for his patient-centered approach and his commitment to advancing fertility care. With that, Dr. Hannam, thank you so much for being here, and I'll turn it over to you. Just in for anyone that has any questions, if you could just put them in the chat and I will make sure that Dr. Hannam addresses them, but we'll also be doing a Q&A at the very end. Dr. Hannam, all you.
Thanks so much, Mimi. Thank you, everyone, for your time tonight. I'm going to be as efficient as I can be. I recognize that it's a commitment away from your personal life, and I hope I can provide some real value to you and to the Fertility Friends Foundation. We're a big at our clinic. We're a big supporter. We're all wearing our green ribbons. And just to endorse this very patient-centric um, organization that is really doing their very best to provide the most access to the most patients possible. Well, unexplained infertility. If you're here for yourself or a loved one, you know what a stressful diagnosis this is. Because it's not a diagnosis at all, is it? It's a person who has presented themselves to a fertility clinic and gone through the investigations, none of which are easy. Blood tests, and it's an embarrassment to do a sperm test, and it's not easy to get a transvaginal ultrasound, and you get these tests done, and the doctor comes back and says, "Well, it's good news, everything looks good, but it's not so great if that's on the background of having trial but not been able to succeed in having an ongoing pregnancy." And so, not infrequently, the team will say, "Well, I guess it's unexplained." It depends on which data source you looked at, how often people claim that this diagnosis of unexplained applies, but it's a pretty high percentage of people. And for those that are in that situation, it can be awfully confusing because on the one hand, to believe all the tests is to say, I guess things are good. I mean, maybe we can get pregnant naturally. Maybe we can just get pregnant this month naturally, and maybe you can. Um, but on the other hand, if you've already been trying naturally for 6 months with perfectly timed intercourse, everything's going really well, then most people who are already pregnant through intercourse will have already achieved success. So by 6 months of well-timed intercourse, it's now a 5% chance per month. And if it's been 12 months of well-timed intercourse, it's approximately a 2% chance per month. That's not zero. It can definitely happen, but it's nowhere near as high as you need it to be. And so coming to the fertility clinic, one would hope to get some answers to direct, ideally, some possible therapeutics. And with unexplained infertility, suddenly all the therapeutics that are available, and it can be difficult. You can be like, well, then what do I do? And the doctor is like, well, You can, what do you want to do? Yeah, they can be terribly open-ended conversations, and you wonder if you're meant to try naturally or do naturopathy or do inseminations or low-dose medications or IVF or all the bells and whistles and surgery. So my point tonight was to do two things. One was to go through the basic tests and why we do it in that way, and when they do come up and empty-handed, what the next level of tests are, and then after that, if like a strategy, like basically what one might do. Now, here's the big caveat before I get going. I can't know you. I can't know your story. I'd be really happy to help with individual questions throughout this conversation or afterwards. You should know that I can't see it on my screen right now, so Mimi's going to interject if the question's pressing in the moment. Otherwise, we'll address them afterwards. But it could be the specific suggestions I offer. They may or may not be exactly applicable to your story, and they may or may not even be a test that are specifically available at the clinic you're at, and that's okay. But because in the world of unexplained infertility, there's always another test. There's always another possible stone to unturn. I think what's more important in this lecture tonight is just to give you a sense of the general architecture. So directionally, where are you going and how will this story probably end up. So, um, spoiler alert: most people with this diagnosis will succeed, but it can be difficult for some. And I just want to set the expectations at every step as well as I can. All right, so let's start at the beginning. You just going to the fertility clinic. You've been trying already for 6 months or 9 months or 12 months, some period of time that the diagnosis of infertility, you're not getting pregnant as quickly as you want or need. You're not building your family at the pace that you would like. And it's time to do some investigations. So the first thing we'll be doing is looking at eggs. Testing comes down to eggs, sperm, tubes, uterus, and overall health. So let's talk about eggs. The real thing you want to know about is how good your eggs are, of course. And there is no test for that as a screening test. Well, there's age, but the tests that we have are tests of quantity, of how many eggs you've got. The best test of egg quantity is AMH. Um, so let's have a look at this graphic here. Look at the green line, that's average. So let's take a patient who is 36 years old, and we're going to go to average, and we'll come across and we'll say, okay, the AMH is something like 18. That's normal. Um, I'm hoping you at home can see right now, based on your age, where your age would probably be. And one of the take homes from this is it's pretty variable. It's quite a wide range. So what is the number that you even want? Well, when it comes to uh, uh, the AMH does not directly tell you how good a quality the eggs are, but they do tell you how well you'll respond to IVF. Now I get it. We're not talking about IVF yet. We're just doing initial investigations. Hopefully, there are ways of getting pregnant. But we all know IVF is the backup to a fertility journey. And so we want to know from the hop, is this backup going to be pretty effective for you? And IVF is most effective when AMH is suggests that there's a good number of eggs. So a good number is an AMH of about 20 picomoles per liter. Um, you can get a AMH done at any clinic across Canada, any Life Labs across Canada. There are two ways of expressing those units: nanograms per milliliter at picomoles per liter. In this, I'm talking about picomoles, okay? So if you're like thinking about that your number is significantly lower than what I'm describing right now, have a look at your results. It might turn out you're in the other units, and you multiply by 7.1, you get picomoles. Anyways, 20 picomoles per liter. That'd be a nice normal number, and it would predict a nice normal response with IVF. You can take your AMH, and that's about how many eggs you'll get. So if your AMH is 20, you'll probably get something like 20 eggs, 15 to 25 eggs, which is exactly the number that we're looking for with IVF. If you have an AMH of 12, maybe you'll get more like 12 to 14 eggs or 8 to 14 eggs. That's why AMH is useful to us. It tells us more or less what's going on. Now, already you can start to get a hint about egg quality. After all, if the number is lower than you would have expected, maybe it's fine, just born that way, or maybe there's a reason, like you have endometriosis, or you've had a lot of abdominal surgeries, something that, or you've had an ovary removed, something that physically compromises the number of eggs available, or maybe the AMH has started to change because a real reason that AMH changes is with age. So just a reminder that there actually is a signal about egg quality, and that is maternal age. Um, if that's frustratingly vague, if you're 37 and you're wondering, well, does that mean my egg quality has changed or not? I can tell you that as a statistical average, it does. But I cannot actually tell you that at an individual personal level. There are people who are 37 who really started to run out of good quality eggs. And there are people 41 years old who still have the majority of eggs being really good quality. Of course, we're all different. These are just expectation management tools. So although your age is important, um, it's a pretty rough guide to egg quality. So to be crystal clear about this, we cannot tell you much about egg quality until you're over 43. And then it's like, okay, yes, egg quality is definitely a part of the story at that point, inevitably for everybody. Um, but before that, egg quantity is the tool that we have as a screening test. Okay, eggs, sperm. These are the main things that we look for with sperm. So I've got little things I have to move on my screen here. Count, motility, morphology. These numbers here will be available to you whenever you look to a sperm test. They'll always give you the normal range, but these are the big three you want to look at. You might want to look at total motile count as well. You'll see it when you get a sperm count. There's a million things that they test. Well, not a million, but like a good 20 things. But these are the main three that they're looking for. Um, and what's so special about being above these numbers? Well, there's nothing uniquely awesome about it. For example, motility, um, over 50% or over 40% by some standards. What if you or your partner's sperm count has a lower motility than that? Maybe it's fine. I mean, after all, it's not really how well they swim that we are too fussed about. It's actually about how well they get into eggs when they finally get there. But we can't measure that directly. The ability to get into eggs, it's called the acrosome reaction, the ability to burrow their heads right into the eggs. And we can't measure that directly. So we measure how well their tails move. And generally, if the motility is up, if the morphology is good, if many of them look like they have a normal shape and there's enough of them, then that indirectly predicts that these guys are able to get into eggs. All right, so the next screening test would be around tubes. Now, I was expressing that egg testing is tough. You can't tell the real thing you want, which is egg quality. Sperm testing is pretty good. If you can see them right under the microscope, so if you're told that it's good sperm, it's probably good sperm. When we tell you about your tubes, gosh, I have to tell you, these are not great tests. It's just they're the best ones that we have. The only way to really see your tubes is to do laparoscopy, to do surgery. We barely do that anymore. It's so invasive. Laparoscopy can cause complications and scar tissue just by doing the surgery. So we really don't do laparoscopy unless we're really trying to be therapeutic, trying to treat somebody. So, um, to do tubes is to just do imaging. That means doing X-rays or ultrasounds. X-rays, well, that's what the histosolubility test is. So have a look at this. This is what it looks like to us when you put dye into a person's uterus. Imagine that we're looking down on their tummy. So you're looking down at their belly button. And behind the belly button, there's this triangle. That's the uterus. It looks like sort of a wobbly triangle. Not the best picture of a uterus. I can't really tell you if that's a good uterus or not. But there's the fallopian tube. So you can see it gets all skinny and then it kind of comes out and it kind of spills out here. And it's the same on this side. It looks a little longer and then it's kind of spilling out here. It's complicated. I cannot tell you for sure that these are great looking tubes. I think they are. I think it's spilling out here. And I think this dilated end looks normal. This looks normal, but boy, you can really miss some subtlety here. So whenever we tell you that your tubes are open, good, that doesn't mean for sure that they're healthy at the end. They might be compromised by endometriosis or other scar tissue, and we wouldn't know for sure. We might tell you that one tube is blocked, but these tubes are just muscles. So you can imagine that it could just be closed down at the moment that we happen to be doing the test. In fact, that can happen to both tubes at the same time. So anytime you're getting tubal testing, you have to take it all with a grain of salt. But generally, if you've never had pelvic surgery if you don't have endometriosis, if you've never had a sexually transmitted disease so bad that you were hospitalized for it, then you probably have open tubes. And if you go and get your testing done and they say, yeah, we saw at least one of your tubes open, probably both tubes are open. Okay, I said there's imaging. X-ray is one way to do the test, but ultrasound's the other. Now look at this. You can see it so much better. You can see why in a modern practice, most of the time, we like doing ultrasound. You can sort of see the I can't see the tubes in this picture right now, but when you're doing the test actively, you can sort of see the tubes. In my opinion, not quite as well as with HSG, but the literature tends to disagree with me on that. They say that both are good for seeing tubes, but no question about it. It's awesome for seeing the uterus. Okay, so same thing. We're looking down on the person's belly button. But now I can start to tell you a bit more about the uterus. So this is the outside of the uterus here. I hope you can see my arrow. And then on the inside, this is the lining of the uterus all stretched out because there's water inside. Stretched out. So how does that feel for the patient? Well, it depends. I hope the doctor is kind and gentle. I hope that at least one of the tubes is open to relieve some of the pressure. But if not, this is uncomfortable because the water pressure is building up inside. Um, well, this is a really good, this is a really clear picture, and this is what sonahistograms tend to look like. Now look around at the bottom here. There's a circle. That's the balloon that they have usually in place keeps the water inside. What's this white stuff here? These are little bubbles. Those are the bubbles that we actually see spilling out the fallopian tubes, but they haven't put too many bubbles in yet. So mostly it's just a normal saline. That's why it all looks black in here. This is a nice normal shape. It looks like it looks like a triangle. You can see polyps. They look like polyps and fibroids look very similar. They look like big circles that are impinging in the way. You can see scar tissue. It looks like bands. Um, and this is very common. See at the top here, it kind of dips down. It just dips down a little bit. That's an arcuate cavity. Arcuate means heart-shaped. It I would say most people on a modern image have an arcuate cavity. If you go to the internet, it can freak you out because, as you can imagine, there are some people where this dip goes way down like this. It used to be back in the day, you could only see those huge dips. So, a very important question for your doctor, if you have an arcuate cavity, most people do, is like, okay, but how big is that dip? According to the literature, everything's okay as long as the dip is under 10 millimeters, under a centimeter. Certainly, I have to tell you, most people have a little mini dip of like 2 to 5 millimeters. That's very common. So you can decide with your clinician if you have an arcuate cavity, if anyone considers it significant at all. All right, that's doing a Sun histogram. Of course, most ultrasounds don't involve doing that. Most ultrasounds will start just as a probe on the tummy. And when you do that, you can look at everything. You can look at the kidneys, make sure all the anatomy is in place. If you really want to look just at the uterus, that's when we tend to do a transvaginal. So that's why when you go to the fertility clinic, most ultrasounds are transvaginal ultrasounds. You just get such a clean view of the uterus and of both the ovaries. When you look to the uterus, it doesn't usually look like this because the two sides are actually touching each other. But when they do that, you can see the lining better. And if you do it in the middle of the cycle, you can make sure the lining's nice and thick and has the right pattern. Okay, so now we're getting to the meat of the lecture. What if you've done all these tests and they're like, yeah, everything's good. AMH is good, sperm's good, one or two tubes are open, uterus looks normal, and we think you're a healthy person. Now what? So, um, now what is often not helpful enough. And the thought is maybe we should go to the next level of investigations. And if this is the position that you're in, you might have thought, well, why didn't they just start with the next level of investigations? And the answer is the next level is just more invasive or more expensive or both. You wouldn't want to wish the next level on literally everybody who walks into a fertility clinic. But that if this is your story and all your tests are coming back as normal and you don't know which direction to go, one possibility is you're going to be like, I gotta go deeper. I gotta try to get some more investigations done. So let's go through those tests again, but in order: eggs, sperm, tubes, uterus, and overall health. Eggs. You gotta know, are these good quality eggs or not? Now, we cannot do that with the screening test with AMH. That was just a quantity test. I already said you can't do it with age alone. Only way to actually know egg quality is with IVF. It's the only way to know. So IVF, it's a reminder, if you haven't done it yet, you take fertility drugs for about 9, 10 days. If your AMH is 20, you're going to get 15 to 20 eggs. If it's lower or higher, you might get a lower or higher number than that. How does that feel? Well, if you're growing that many eggs, it feels quite bloaty. Um, and that can be that can be significant for some people sometimes. But with all the high hormone levels and the bloatiness come lots of eggs. The procedure itself, if there's good anesthesia, then it should be a straightforward procedure. It's transvaginal again. A needle goes through tissue, the top of the vagina, usually frozen, and so the needle goes through frozen tissue and pulls those eggs out. The recovery is very individual. Those ovaries will still be bloated, but now bruised because there's a needle inside of them. So the next few days are tender for sure. But meanwhile, we've got those eggs in the lab and we can mix it with the embryos. Now, this is the first time that we've actually seen your eggs. They'll often talk about eggs that they can see on ultrasound, but those are actually the sacs of fluid around the eggs. Eggs are microscopic. So we see the follicles, but we don't see the eggs, not until we do IVF. It's possible. Right there, you see the egg for the first time and you're like, oh, this explains it. Not the explanation we wanted. They're unusual looking eggs, but there we go. It's not unexplained anymore. Or you put the sperm in and just nothing happens. You put they just either don't go in or we put them in through ICSI and it just doesn't go. That's that's an explanation, not the one that you wanted. But again, you do actually learn what's going on. Now, hopefully what's happening, and what happens most of the time, is you get a good blast rate. A blastocyst. A blastocyst is a day 5 or 6, sometimes day 7 embryo. So it's been growing for a few days and it's become so big that we can barely count how many cells there are anymore. About 120 cells. There's a little inner cell mass, and around that there's something called the trophectoderm. That's going to become the placenta. So we've got a pretty advanced little embryo there. You can freeze it, and just before you do, you can take a biopsy. You take a few cells from that placenta before it gets frozen. So the reason to do that is you can do genetic testing of those cells. Now, those cells around the placenta represent, not directly, but they represent the inner cell mass, the baby. So what that means is that by doing a trophectoderm test, we're getting a strong indication of the genetic competency of the embryo itself. Now, as it turns out, the PGT, that genetic testing that we're doing, is actually mostly a function of eggs. And that's because the eggs take their own DNA and that of the sperm and they bring them together. And then it's the eggs that are responsible. The eggs have the mitochondria that gives the energy for the cells to divide. And so if it's a problematic egg, it'll present quite possibly through an abnormal balance of the genetics as those cells divide. Um, I would have thought that it would be equally problematic if the sperm DNA was a problem. But the testing that we've been doing with PGTA is more directly a test of egg quality than of anything else. So if you have a lot of embryos, a lot of blastocysts, they've done well, and you do the genetic testing, and a lower fraction that you would have anticipated come back as genetically balanced, that's the unexplained infertility diagnosed right there. Now remember that doing that genetic testing, it's not a requirement, it's a diagnostic test. It doesn't actually change the chances of having a baby, but it does change the experience of it because you won't have to transfer embryos that tested as aneuploid, as having the wrong number of chromosomes. If it's the wrong number, it tends to be incompatible with life. So by skipping all those transfers, it means you have a higher rate of success per transfer. So again, you don't increase the chances of having a baby, but you're probably going to get there faster because you're more likely to transfer a high quality embryo earlier. This is our internal data, and what it shows is that broadly speaking, you just have a higher pregnancy rate per transfer when you do the genetic testing. It's higher, but it's not perfect. As you can see, it's around 60%. This is the chance of having a baby. The positive pregnancy test rate is higher than this, but 60%, not 100%. It's good. The way the math works is if you do this transfer and it doesn't work, you do another one, it's 84% chance cumulative pregnancy rate. Still not as high as you would want it to be. And that's because the type of genetic testing we're doing, PGTA, it is limited. It's just testing the number of chromosomes available. So if you've done this already, if you've done IVF and you've done genetic testing of embryos, and they're like, yep, everything's normal, and you've transferred one, two, even three euploid embryos, and you're still not pregnant, that's still unexplained. There is a deeper level of testing available. It's very new. It's just coming to Canada. It's just coming to the US. We're no further behind than anywhere else in the world. And I would make a strong argument that Canada actually has one of the strongest IVF center, has some of the strongest IVF centers in the world right now. One of the things that's increasingly be available is something called PGTG. So this is where every single embryo gets not just a test of the chromosomes, but a full the full genetic story. So there's 20,000 genes in us humans, and they're able now to look at everything all at once. It's an extraordinary test. It is expensive. I'm sorry, I don't know the actual numbers right now, but let's use some placeholder numbers. $2,000 an embryo, numbers like that. It adds up very quickly. But what they're able to do now is find so many genes that it's actually getting complicated. We're so at the leading edge of things that it's very difficult for the clinicians, for your doctor, for the counselors to tell you exactly what all this information means. But increasingly, they are able to associate some of those variants with lethality. So they're increasingly able to say, probably this embryo, although genetically balanced, it's got this single gene in here that we don't like the look of, probably associated with lethality. We should push that aside. They won't say yet that it will never work, but they're increasingly saying this is the one that will. I'm giving you this visibility not because I think everybody needs PGTG. I do not think so. However, I'm super excited by this technology because until this point, unexplained infertility that was not given a diagnosis through PGTA has been a huge source of stress. Okay, let's pull back from this a little bit. What if you are not, what if you've been given unexplained infertility and you haven't done IVF yet? You're like, got it, IVF will be good for my eggs, but we still need to know more about sperm. There are deeper tests of sperm that you can do. Um, there's the thing that I would ask you to seriously consider is looking into a DNA fragmentation test. Now, there's a reason we don't just do DFI for everybody right from the hop. It costs extra money. It's not going to be covered by your provincial insurance. And like all these sort of add-on tests, it's not exactly certain exactly what the results may mean. What they're doing it is they're taking the sperm and they're adding acid to it and seeing how badly that breaks up the DNA. So, it's kind of a weird test. It's not like that happens in nature. We're not adding acid to sperm when they're trying to get pregnant naturally, but that's what the test is. And so if it's still really stable after adding acid, that's good. It's nice and stable. But if it all breaks up, that's a high DNA fragmentation. So of course, add acid. There's always going to be some fragmentation. For some guys, it's like 7%, 10% fragmentation. Not a problem. For some people, it's 20 or 30% fragmentation. Probably not a problem. For some people, it's 40% or more. Probably a problem. It probably says that that DNA, when exposed to a stressful circumstance, like arriving at an egg and getting into an egg, the DNA just breaks up really easily. Um, the good news about this test is it's very reproducible. It's very easy to do, and so what that means is that oh, I'm just letting EN know that your camera's on. I don't know if you mean to be doing that, but we're looking down at you. You might want to turn it off. Up to you. Um, uh, uh, that that sperm if the DNA breaks up really easily, you can look to various therapies that might be valuable. For example, there are some vitamins that men take. I'll give you an example: vitamin E, zinc, selenium. I strongly recommend speaking to a naturopath about what might be best. But the good news here is you can take these supplements or you can do lifestyle changes and 3 months later do another DFI test and see if it made a difference. That's why I like DFI. It's something that you can do that helps you optimize sperm to the best of one's ability. Okay. I just thought to also focus on total motile count. And this is something that doctors don't always focus on. But when it comes to unexplained infertility, sometimes the sperm's low, and they're like, "It's okay, it's low. That's not great, but everything will be okay if you just do IVF. We'll just put the sperm into the eggs, and then you do IVF, and you just don't get that many blastocysts, or those blastocysts are not resulting in pregnancy." And the doctor's like, I don't know why that's not working. It's unexplained." But I need to tell you, if the total motile count is less than 2 million, we see it very commonly. In fact, there was an egg donor bank that I worked with out of the US, and they used to like give the money back. If the couple didn't get pregnant with donor eggs, they're like, not a problem, just give all the money back, unless the guy had a total motile count of less than 2 million. And then they wouldn't guarantee that anymore. And I can't tell you why. I don't know what that's about. I don't know why, if there's less than 2 million motile sperm, is associated with a materially lower pregnancy rate, even with donor eggs. But I've personally really taken that to heart. And there's going to be times when you try with a low sperm count and then you try again and try again. It's just when the total motile count is under 2 million, it's not exactly unexplained. It's speaking to severe male factor. And if that's diagnosed and you've tried everything, or the time is right for you, that's when people would turn to donor sperm. Okay, what about the uterus? Well, we talked about polyps and fibroids. If they're in there, that's day surgery usually to take them out. If there's scar tissue, you might see a surgeon to take them down. Um, if your lining is thin, they'll offer different tests, different treatments for thin lining. But if everything seems normal, it's a bit confusing. And there are tests that people have been doing for a long time. The endometrial receptivity assay test, it's a biopsy. ERA test is a biopsy. That means they place a catheter through the uterus. There's a suction for half of women. They don't feel that much. The other half, it hurts for about 6, 7 seconds. I don't like doing the test. It's unpleasant. But if you need to know, you need to know. And they take that sample and they'll pass it through to a lab and look at it under a microscope. I, these tests are pretty controversial. What controversial means is they've not been proven very well to be associated with outcomes. It's true, there are some people with a huge microbiome overgrowth. So what that means is that something has gone right out of whack inside the uterine lining, and if we could just reset that, maybe with antibiotics, that everything will go well again. The problem is the so-called perfect microbiome has not actually been defined all that well yet. And so while these tests exist, and while our team uses them, it's not for everybody because it's not clear when the results are abnormal exactly what it means to initiate treatment. So I'm acknowledging that these tests exist, but I'm also saying that when it comes to unexplained infertility, they're incredibly frustrating because as you go through these investigations, you may or may not really get answers, and the treatments themselves may not be as effective as they need to be. So the reality is, if you're transferring lots of genetically balanced embryos and everything seems great, then at some point, after your third transfer or your fifth or your seventh, at some point, someone's going to say, I don't know either why this isn't working. We've done all the tests there are. It's time to look to a surrogate. There's no perfect moment when that's the case, but that can be a treatment for unexplained infertility when you've just gone through the sequence of treatments and they have continued to not work. You feel me being pretty vague around uterus here. This diagnostic matrix is somewhat helpful for us internally. Let me just take you straight to the definitive gold standard. That's hysteroscopy. That's actually someone putting a camera inside. So if you've had an HSG or a sonohistogram and you've had a euploid embryo transfer or two euploid embryo transfers and you don't know what's happening, one possibility to talk with your clinician is to talk about doing a hysteroscopy just to look inside to see if there's anything that looks different for you than for anybody else. Okay. Eggs, sperm, tubes, uterus, and overall health. Now, overall health. Oh, you guys, of course, this can be anything. What I've put up here is a pretty common set of screening tests that we do, and I would argue most clinics will do for most people most of the time. They're not all directly fertility tests. Infectious diseases, I'm sure your clinic's doing this, but these aren't really fertility tests. These are just to make sure that it's safe for everybody, particularly in the lab, to be working with the sperm and eggs. Hematology, your CBC, yeah, it's useful, but really it's about pregnancy and we're maybe making sure that you're safe for the procedure itself, for the egg retrieval procedure. Rubella immunity, yeah, again, these are not fertility things. These are making sure that you're all set up for pregnancy. Now, thyroid, fertility thing. If this is off, then we can treat that before you get going, and that's just one of those screening tests that many clinics will do. And if it's off, it's easily treatable. Hemoglobin A1C, part of the making sure that you're not diabetic. And what about vitamin D? Well, the evidence is not super strong, but keeps going in the same direction that having a replete vitamin D, having enough vitamin D, makes for better quality eggs. I want to say it's better quality sperm as well. We've not been able to prove that at our clinic yet. We suspect it's true. We just don't know that yet. But we seem to get better quality embryos when eggs, at least, are come from people who have a good vitamin D level, especially as Canadians in the spring. It's been a long winter for most of us, and something to consider. You're welcome to get your level checked, or for most of us, you can just start taking vitamin D. That can make a difference. But what kind of a screen is that? Look at all the screening tests that are available out there. You get a full body MRI. You could, oh my gosh, what isn't there to be done? And that's the dilemma, isn't it? Especially when it comes to unexplained infertility. Because there are a boatload of tests around health, in the end, you're going to find something. That's just the way tests are built. Most tests are built to have a 5% positive rate. So what that means is you do 20 tests and something's going to pop out. That's why the immune system testing that you get done is always so eye-rolly for fertility because if you do enough autoimmune tests on people, you're gonna find something. But more importantly, what are you gonna do about that? And the answer is things like blood thinners, things like immune system modulators. And as we start to give people these drugs, we're not like there are real side effects with these things, and they've been just shown over and over and over not to make a difference for outcomes. I don't want to say that myself or my clinicians are above this. We do this too. We have a full autoimmune treatment package that we'll give to people after the third failed euploid transfer into a healthy person with a ideal looking uterus and a perfect lining. We're throwing our hands up in the air as well, and we don't want to rush anyone to surrogacy who doesn't want it. We're just as tempted as you are to be looking at immune system modulation treatments, but I just want to be crystal clear that there's just no evidence behind them, and that's why they reside in a problematic space. All right, I'm doing a lot of talking, but I promise we're at the end here. Now, what can you do naturally? You already know these things. I've got nothing new on the screen that you don't know. Of course, you shouldn't be smoking. Of course, you should exercise sometimes. Yes, there's such a thing as too much exercise. The reason you want to keep your vaccines up to date is if you get really sick, you get super inflamed, and an inflamed person has a hard time holding on to a healthy pregnancy. If you have a chronic health condition, yes, you want to optimize that. Healthy weight, exactly the same thing. You already know this. If you're terribly underweight, that's an unusual stress to the system. Same with if you're too heavy for your natural set point. It's the same thing with oral health. If you lots of evidence showing that if you don't keep your teeth healthy, that you're showering your system with bacteria all the time, that just creates generalized inflammation. Um, and what about this? Look, this is the worst part of all this. Please understand if you're the person with unexplained infertility, of course it's stressful. And the worst part about talking about this is the blame implicit in this. Oh, if you just relax, everything's going to be okay. There are no perfect tests to tell someone if the stress that they have is good or bad stress. But let's be extremely clear that stress is embedded into not just your story, but everybody's story, whoever comes to a fertility clinic. And as you know, most people who come to a fertility clinic will in the end succeed, even with all that stress around. Now, let's make it about you to some degree. I wish I had a specific test that I could tell you about today. We're really looking into this, and as soon as we know something, we'll be telling the world about it. But in the meantime, there is no specific stress test. And the idea that it's not uniformly negative is very real too. Let's acknowledge that stress is also part of what gets us going. It's part of what propels us. It's part of what a fully active and engaged life can be all about. It's not about having no stress. It's about having not too much. Okay. So are you meant, if you are freaking out, if you know you're not coping, should you do anything about that? Is that going to help with your chances for getting pregnant? Well, I'd like to say it will, but here's what I can say absolutely for sure. It's going to help you keep your head on straight while you make extremely difficult, expensive, and complicated solutions for yourself, with your partner, with or despite your family and friends, with or despite the significant investment in time and costs. Being able to keep one foot moving in front of the forward is absolutely critical to any success that you can ever hope to enjoy. And anything that is consistent with a reasonable lifestyle that's going to help you, up to including, please allow yourself to take breaks as necessary. I'm not asking you to like drop out of fertility treatments for a year, but it's amazing what 3 months can do to just reset yourself, reappraise where you're at, make sure you're going the right direction for yourselves. Um, uh, uh, I think that I am not trying to say that you reduce your fertility, reduce your stress, you'll have a baby, but I am saying that only you can really manage this, and only you know when it's time to seek help outside of your relationship. All right. Um, let's make a plan. You've done your initial investigations, and you're sitting there with your doctor, and they're like, "Well, you can do whatever you want to do." Here's where we're coming from. Where we're coming from is we know that in general, a person with unexplained infertility statistically fits into average success rates. So average success rates are pretty easy for us to quote. We can say, well, yes, the average success rate with IUI is, they'll quote you a number, 10%, 15%, 20%. Probably they'll quote you numbers like that. Is that true? Yeah, it's true. It's unexplained. It fits exactly into the average numbers for IUI. What do I think about IUI? I don't really like IUI that much. I think those numbers suck. So I don't recommend doing more than a couple cycles. You can do it absolutely as purely natural cycles, but I like it if there's more than one egg available. That's with clomiphene. The problem with clomiphene is there's a side effect. It blocks estrogen, thins the lining of the uterus. So clomiphene quickly turns from a good medication to a bad medication. In Canada, what we actually, and in my clinic too, what we mostly use is letrozole because it doesn't have that same side effect profile. You're less likely to get two eggs. That's too bad. But you're more likely to be able to do more cycles. And especially because as soon as you're in the world of IUI, you're like, I don't know if we time this one right. Maybe we do it again. You just never really know how many cycles you're going to do it for. There's a lot to be said for letrozole IUI. This is our first line. Again, Canada, world leader for fertility stuff. I truly think this is the best first line, although Americans are still calling out clomiphene. Um, the problem with natural cycle, only one egg. Gonadotropins, those are the injections. Look, you take injections, you might get 3 to 5 eggs. You're looking at a high risk of high order multiple pregnancy and enough success rates given those risks. I think unexplained infertility, I am sorry to say, is a strong indication for IVF later. Yes, if this was my partner and I, it was truly unexplained, not secretly just age related, but actually unexplained. Yeah, I would totally try a couple of cycles of IUI because what if it worked? But please understand that a couple cycles of IUI, probably, with this and that and meeting up with your doctor and blah, 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 it probably takes 3 to 5 months. And then ideally, you move into IVF because with IVF, you're finding out about eggs and sperm and if they're actually working. If you can do the IVF with the genetic testing, you're going to get so many more answers. It's a pretty rare couple indeed who do IVF with PGTA and don't get their answers. I talked about it tonight because we have to. This is a talk about unexplained infertility. But most of the time, if you turn to IVF, it's a double whammy. You're going to get the answers you need, and better yet, you're going to get pregnant. The success rates with IVF are so high. So there we go. Uh, just a blah blah blah. That was a long talk. Um, Mimi, I've reached the end. I hope that was helpful for people who are listening. I'm not in a position to see if any questions were asked, but if they are, I'd be happy to answer them.
Dr. Hannam, thank you so much for your presentation. It was so insightful, and there's lots of questions in the chat. So, if we can just start off with the first one here, and if anyone else has any questions, feel free to put it in the chat. So, the first one that we have is, hello, Dr. Hannam. My husband has globozoospermia, and we've gone through ICSI and microfluidic IVF treatment, which has been unsuccessful. Is there any treatment or procedure for us?
Well, there is but this sounds like that story that I gave about a total motel count of under 2 million. So I just want to acknowledge that it does influence likely outcomes more than we would like, and unfortunately, there's not a specific test that I can give you that would encourage you to keep trying or not. So one approach might be if you've done, and I'm sorry, I don't know about the finances here as I say this. If you have done IVF at one clinic before, and you've tried that and you've not had the embryo outcome that you would like, my advice would be to change labs. Try it at a different clinic. I would say the same thing to my own patients. If it didn't work at my lab, try it at another lab. If it doesn't work at two different clinics, it's a pretty clear indication that the technology that we have today is insufficient to give you a reasonable chance for pregnancy at IVF. Then you have that important decision as to whether it's now time to use donor sperm or if it's important to you to keep trying with IVF. That's the problem with IVF. You can always keep doing it another time and another time after that. But I would ask you to consider two different labs, two different cycles before you made those really profound decisions about multi-cycle IVF or donor sperm.
Thank you.
Um, yeah, I'll let you know that various things have been tried, including doing aspiration of sperm. That means actually sticking a needle into the testy, pull the sperm out when he's a little bit immature, maybe using the hope is a little immature sperm didn't get exposed to the final maturation steps. Maybe they were the problem. Um, uh, these things have, broadly speaking, have not been successful, but there's always individual stories. So maybe my last piece of advice would be to speak to your urologist, not an REI. We're REIs. You can tell the difference because REIs did OB-GYN, and the male specialists came from urology. So I would speak to a urologist who has a special interest in fertility to ask them if they think there's anything that they could do that would amplify the quality or the selection process of sperm.
Perfect. Our next question
Mimi, you've
is,
done a lot of sperm stuff yourself. Was there anything that you would add to that? I'm
I
not trying
think
to put
you,
you on the spot, but like I'm just making sure that.
I think you hit it all on the nail there. I think you got it
Okay.
all.
Okay.
Our next question is, what is the difference between a sonohistogram and an HSG, or are they the
There
same?
you go. Yeah, HSG, that's the X-ray test. It's awesome for seeing fallopian tubes, but honestly, we don't do that many HSGs anymore. We do sonohistograms. They're broadly easier to tolerate. If you trust your doctor and they're gentle, it can be a very accessible test. And you just see the uterus so well. Do you see the tubes that well? No, but no test do you see the tubes all that well. But the difference is HSG is an X-ray test and a sono is an ultrasound test.
Perfect. Next we have, hi, Dr. Hannam. Thank you for your presentation. Very clear and incredibly useful. How often is PGTG recommended? Is it only suggested when none of the embryos are considered high quality?
So PGTA is and remains the standard across Canada and at my clinic right now. PGTG is super duper new. And so there is in no way is there a community standard for when it should be offered or even if it should be offered. I'm taking you right to the edge of what we understand today as valuable. If you'd like to look into it a little further, look up Genomics, Juniper. They're really at the leading edge. I trust them very much. My lab team, we're associated with CCRM based out of Denver, Colorado. They're not offering this level of PGTG yet. They think it requires a little bit more investigation before they do, but it'll be coming inside the next 12, 24 months. So I'm just taking you right to the leading edge. But this specific question was about embryo quality. Do you do it when there's low embryo quality? No, you would do this when embryo quality looks amazing, when PGTA is normal and you've done many transfers that haven't worked. That's when this PGTG would be of its greatest value.
And our next question, this was when you were doing the health screening slide. Why just TSH? Why not T3 and T4?
Oh, I was just giving you a screening test. That's all. TSH is a great screening test. And then when it's time to look deeper, then either you with your reproductive endocrinologist or they might refer you to someone who focuses just on thyroid. Will almost for sure be doing T3, T4, anti-thyroid antibodies. There's a whole world of thyroid stuff there. It was just the initial screening test.
Okay, and the last question in the chat right now, we've done IVF, had 4 euploids after 1 round. What answers does this truly give us with our unexplained diagnoses? Could it point to an implantation slash uterine receptivity issue?
Yeah, it does to me. So that's exactly right. So if this in this story, taken the way I understood it just then, it was a single round of IVF that led to 4 euploid embryos. So first of all, in and of itself, that's awesome. Okay. Now I know this is difficult for people with unexplained infertility because they're told all the way along that everything's awesome. So it's difficult, but it is objectively really good. Theoretically, that's if it's two transfers of a euploid embryo leads to an 84% chance of having a baby. In theory, 4 euploid embryos could well result in having statistically could well result in having 2 children. So we're like, okay, this is awesome. But I would agree, you've not actually gotten a diagnosis at that moment. So what's the next step? The next step is to be placing these embryos inside. Now, maybe the problem was already solved. Maybe the problem was that those tubes were not as good as everyone told you they were, and this is actually the first time you've ever had your sperm and your eggs to come together, and so there's literally nothing for it. You got to do an embryo transfer, and then if that doesn't work, yeah, you have to do another embryo transfer. I honestly wouldn't overthink it until you've gone through 2 embryo transfers. You're right, you've not been given a diagnosis yet. But if you succeed with that first or second transfer, you're like, oh, okay, well, I guess there was a problem and we solved it through the IVF part. I guess that was probably a sperm couldn't reach the egg issue. Frustrating, you'll never know for sure, but that's probably what it was under that circumstance. I would just do 2 transfers. I would. And you would be working with your clinical team to try to time those to the best lining possible. So a great lining has a triple line appearance and is 7 millimeters or more. That's not everybody's story, and I know people who have been getting pregnant on 6 millimeter linings and 5 millimeter linings. But I'm just giving you what the gold standard would be for confidence. Um, you might do 2 transfers before meeting with your clinical team and reassessing where exactly you're at and what the next steps might be.
There are a couple of questions that just came in now, if that's still
Sure.
okay. This is from the first question, the person that submitted the first question. What exactly is globozoospermia? In our case, all the sperms were missing acrosome. We had two embryos, 2AA and 2AB. It was unsuccessful, as I mentioned earlier. What is the best treatment for us?
Global zoospermia means hardly any sperm. That's foundationally what it means. Okay. In your case, the sperms are missing acrosome. So the acrosome is the head of the sperm. What that suggests is when they're looking at the sperm, they don't trust that these guys have the ability to actually get into eggs. Okay. Now then you had two embryos, and look at the letters here, double A and AB. That means that the embryologist thought they were good quality when they look at them under the microscope. Then you've got some numbers here, twos. Those are both twos. I should let you know that different labs use different numbers. So unfortunately, I'm not in a position to tell you if those are good size embryos or kind of small embryos. I'm not sure. And I would want, in your position, I would want you to check in with your team. If they were slightly small, you've actually got an answer that tells you that the embryos were not growing as large as they might have, which means that there was a blastocyst development problem. I'm just going to tell you the scoring at our clinic. At our clinic, one is small, two is small, three is good, four is good, five is good, and six is huge. Like it has to be transferred. So we look for three, fours, and fives. That's what we like to see. And we'd never let something go past size six. So for us, a size two would be a small embryo, but I'm afraid I just cannot provide you any more specificity than that because I don't know the nomenclature system that your lab uses.
All right, and we just have one last question here. We've done two IVF cycles, the first one at one clinic and the second at yours. Between the two rounds, I had 26 eggs retrieved, but none resulted in healthy embryos. Only two embryos resulted and both were unhealthy. Should we consider PGTG, sorry. I am 36, husband's 40, DNA for egg 16.
So I'm first of all, I'm so sorry for the experience that you're in, and this is the fear, isn't it, from the beginning? So you've had between the two rounds 26 eggs. That suggests that you did respond well to stimulation. I'm presuming then that they were telling you that your AMH was good because those are good responses. 26 eggs, an average of 13 per cycle is really good. You've also done exactly what we were hoping you'd be able to do, is if it didn't work at one lab, you tried it at a different lab. Um, this includes ours. Ours is quality controlled out of Denver, Colorado, and CCRM is not an inexpensive lab, but it's just known for its really high quality its internal quality control structures. So I'm not saying that our lab works for every embryo all the time, but if that's two different stories at two different labs, that is a real worry. I'm sorry, I cannot say that PGTG is going to be the answer. PGTG is only going to be the answer when the embryos grow really well, and they're so numerous that they're all able to be biopsied, and and through those biopsies, answers can be found. I suspect that over time, their databases through PGTG will build up so that even underdeveloped embryos will have a chance for at least a diagnosis, but they don't have the algorithms ready there yet. Um, my recommendation would be this: contact Juniper directly. They might um, uh, uh, be working with various labs through the states already that are offering such testing for underdeveloped embryos at this time. But I think you'd be doing that as much for closure, as much for an answer as anything, because there won't be any therapeutics involved with that. So I'd be cautious going down that path. Um, Genuinely sorry for these challenges that you're facing. And I do not doubt at your age, any clinic that you go to is going to suggest, yeah, why don't you do IVF again? It puts you in a tricky bind. And I do think it's before doing IVF again, it would be nice to understand what your new lab would be offering that would provide a material expectation that you're going to be getting a higher number of embryos developing. But I'm afraid that I would not recommend PGTG as the answer to that challenge.
Perfect. Well, it's just after 9 o'clock, so I just want to be mindful of your time. And we're going to close the session off now then. I just wanted to say thank you so much, Dr. Hannam, for joining us today and sharing your insights. And thank you, everyone, for joining us this evening. We hope that you found this session helpful and informative. And please feel free to join us for our next seminar. It's called Choosing Egg Donation, Legal Realities and Emotional Journeys with Michelle Flowerday and Emily Getz, and that's happening May 12th. And this is part of our Fertility Guide webinar series where we'll be sharing expert insights each month until July. So feel free to check it out on our website, fertilityfriendsfoundation.com. Thank you, everyone. Have a great night.
Thank
Thank
you,
you.
everyone. Thank you so much for your time. Thanks, Mimi.